So today we're going to be talking about hypertension. Hypertension is persistently raised arterial blood pressure. Hypertension can also be defined as the level of blood pressure above which treatment does more good than harm, so thresholds for diagnosis vary. Hypertension is a major cause of premature death worldwide, with upwards of 1 in 4 men and 1 in 5 women affected. That's about 1 billion people worldwide. The burden of hypertension is felt disproportionately in low and middle income countries and communities. Often, hypertension is asymptomatic, at least until late in the course. Persistently elevated blood pressure over time typically results in damage to blood vessels, especially smaller muscular arteries and arterioles. This leads to organ damage, and thus complications which include stroke, heart attack, heart failure, aortic aneurysms, kidney disease, vascular dementia, and peripheral artery disease. So there's a wide variety of definitions used for blood pressure measurements to define hypertension, but today we'll look at NICE's definitions, and these vary depending on age and the setting. Hypertension is generally suspected if there's a clinic blood pressure above 140 systolic, so that's the top number, or greater than 90 diastolic, the bottom number. This should prompt you to then confirm the diagnosis with either a home blood pressure monitoring reading, which is usually a 7-day blood pressure diary taken by the patient, or ambulatory blood pressure monitoring. So this is a cuff, a recorder that the patient wears throughout the day. So stage 1 hypertension is defined as a clinic blood pressure that's greater than 140/90, but less than 160/100. This should then be followed by home blood pressure or ambulatory blood pressure readings. And to diagnose or confirm the diagnosis of stage 1 hypertension, you need to get one of these readings, systolic greater than 135 but less than 150, and diastolic greater than 85 but less than 95. For stage 2 hypertension then, you need a clinic blood pressure greater than 160/100, followed by ambulatory blood pressure or home blood pressure readings greater than 150/95 but less than 180/120. And then for stage 3 hypertension or severe hypertension, you'd need a clinic systolic blood pressure of 180 millimeters of mercury or higher, or a diastolic blood pressure of 120 millimeters of mercury or higher. Now let's talk about the target blood pressures. And these are from the NICE guidance, and they vary based on your age, and they vary based on comorbidities, and they vary based on whether it's a clinic blood pressure, which is just when you're suspecting the diagnosis, or when you're confirming it with ambulatory or home blood pressure monitoring. So this again is about balancing the risks and benefits of treatment. Because like anything, antihypertensives come with their own risks, and these vary based on the antihypertensive agent used. But in older people, generally, the risks are higher. And that's why in 80 years and older, the clinic BP target would usually be below 150/90, and the ambulatory blood pressure target, or home blood pressure target, whichever one you use, should be below 145/85. So these are evidence-based targets. In the hypertension in the very elderly trial, or HIVET, they found that even after adjustment for baseline frailty, the blood pressure target of 150/80 in adults aged 80 or older was associated with lower mortality. Other large-scale studies have shown that patients with frailty who showed a systolic blood pressure below 130 millimeters of mercury were found to have an excess of all-cause mortality, without benefits to cardiovascular risk. So how would you explain hypertension to a patient? So it's important to recognize that hypertension doesn't have any symptoms. Treating hypertension involves usually taking our medicine for the rest of your life, alongside lifestyle changes. So to do this, you need to have a shared agenda with the patient. To develop that shared agenda, you need to explain the reasons that you're treating the blood pressure. This involves communicating the complications of untreated high blood pressure. So these include stroke, heart attack, heart failure, aortic aneurysms, kidney disease, vascular dementia, and peripheral artery disease. Hypertension can also be classified as primary or secondary. Primary hypertension is by far the most common, and that's 90% of hypertension in adults to 95% of hypertension in adults. It's also known as essential hypertension, and we don't know why it happens a lot of the time, but we do know the risk factors, and these are classed as modifiable and non-modifiable, and we'll go into those a bit later. Secondary hypertension is less common. Now, depending on where you look, this is somewhere between 5% to 10% in adults, and it occurs as a result of other identifiable pathologies. Now, it's also important to mention white coat hypertension, which isn't true hypertension because it just means blood pressure that's raised in the clinical setting, but not in other settings. So first of all, let's look at primary hypertension and the risk factors for primary or essential hypertension. Then once we've done that, let's look at secondary hypertension and the conditions that can cause the blood pressure to be persistently elevated. So for primary hypertension, we have modifiable risk factors, which are mostly associated with lifestyle factors, and we have non-modifiable risk factors. Modifiable risk factors include obesity, excess salt intake, lack of exercise, stress, smoking and nicotine in general, diabetes, and moderate to high alcohol intake. Now, non-modifiable risk factors include older age, family history, ethnicity, particularly African, Caribbean, or South Asian ancestry, male sex, if under 65 years old, or female sex, if greater than 65 years old. So it is very important to note actually that up to 65 years, women tend to have a lower blood pressure than men, but this completely shifts in older age, and women tend to have a higher blood pressure than men. There are also genetic factors that play into things. So in twin studies, they've seen that twins have a higher risk of hypertension. So genetics are a non-modifiable risk factor. It's also really important to note that social deprivation is a major risk factor, and people from the most deprived areas of England are 30% more likely to have high blood pressure than those from the least deprived areas. So how do we diagnose hypertension? So it's important to measure blood pressure in both arms during consultations and repeat if there's more than a 15 millimeters of mercury difference. This is important because there's a number of conditions that can affect the blood pressure in both arms, and it's important to be able to identify these. If the blood pressure is greater than 140 or greater than 90, you should take a second measurement towards the end of the consultation and record the lower as the clinic blood pressure. If that clinic blood pressure is greater than the diagnostic targets for the age of the patient, and again that is based on age, especially if they're over 80, if they're more frail, it's important to confirm the diagnosis. You shouldn't diagnose from the clinic blood pressure because they could have white coat hypertension, they could be in pain. There's a number of reasons why the blood pressure in clinic shouldn't be used. You should confirm the diagnosis with the ambulatory BP. One of the best ways to do this, because ambulatory BP, there could be a bit of a wait time to get that diagnosis, to get the kit, to do a 24-hour blood pressure reading or Holter. So at any major pharmacy, you should be able to get a reliable blood pressure monitor that a patient can use. They're usually only about 15 quid or something like that. So one thing you could do is signpost your patient to their local pharmacy to get one of these SFIGs, and you can give them a printed or electronic home blood pressure diary. And the idea is that they take readings morning and evening in the comfort of their own home, and they do that for 7 days, and you can work out the average. And based on that average, you get a reliable diagnosis of hypertension. So I've attached a sample blood pressure diary to the main text of the article, but they can be easily found online, just so long as you're using a reputable source that has some instructions for the patient as well. So now we're moving on to consider secondary hypertension, and although it only makes up 5% of hypertension, it's still very important to consider because hypertension is extremely common. Going back to the numbers I was saying before, We're talking about 1/4 to 1/5 of the adult population. So 5% of that is still very significant. So it's worth keeping in mind some of the causes of hypertension that are secondary to other conditions. It's more important to think about secondary hypertension in the presence of symptoms and signs that could suggest something else going on that's driving it. So common things include sleep apnea. So if someone's got any of the risk factors that you might see in the stop bang score, especially snoring or daytime sleepiness, especially in the context of increased neck size, especially obesity, especially if there's any family members who've witnessed any apneic episodes in sleep, you can consider hypertension secondary to OSA, and this is a reversible cause. So this is very common. Other common causes of secondary hypertension would include renal causes, so particularly CKD is a leading cause of secondary hypertension. Then you move into the rarer causes. So things like renal artery stenosis can cause a secondary hypertension. So this is something that's treatable potentially with a angioplasty or a stent, and it's a narrowing in the arteries that go to the kidney, and it can cause high blood pressure and fluid retention. And it's important as well because even if we can't do a stent, it's important to avoid ACE inhibitors in renal artery stenosis. And it's something that we can look for using ultrasound. Other conditions include endocrine conditions such as hyperthyroidism, Cushing's syndrome, so excess of corticosteroid, hyperaldosteronism, so this can be Conn syndrome, which is uncommon, but hypertension could be the only symptom. So in this case, you can do a straightforward blood test and aldosterone-renin ratio, but if you're doing this, it's important to note that it needs to be sent straight to the lab. There are also cardiovascular disorders which can cause hypertension secondarily, so coarctation of the aorta is one. And in this condition, you'd usually see sort of hypertension in the left arm and reduced blood flow in the right arm. You can also have hypertension secondary to pregnancy, so that's preeclampsia. There's pharmacological causes, so alcohol, cyclosporin, the combined oral contraceptive, but not the progesterone-only pill. And hypertension is either a UMEC3 or UMEC4, so either a sort of absolute contraindication or risk-benefit contraindication to the contraceptive pill. In most people, the combined pill can increase the blood pressure by 3 to 4 millimeters of mercury, something like that. There's another condition that's rarer, but is worth entering your differential if you have a newly diagnosed hypertensive woman, ages between 20 and 50 years. And this is fibromuscular dysplasia. It's a condition that causes structural changes in the tissues of the arteries. And it's more common in women, about 80% female predominance. And it can cause things like carotid stenosis, renal artery stenosis, and it's probably an underdiagnosed condition. I think it's something like 1 in 25 people going for a live renal transplant, they detect that there's some renal artery fibromuscular dysplasia. So that concludes this podcast about the definition, the diagnosis and causes of hypertension. And stay tuned for another article and podcast about the investigations and management of hypertension. Thank you for listening.